I'm your host again today, Dr. Suzette Sutherland. I'm excited to have Dr. Kelly Kasperson as our guest for this special episode discussing a variety of issues pertaining to women's sexual health. Good morning, Dr. Kasperson.
Good morning. Thanks for having me.
So let's move into the area of desire then, libido, and where we are today with that. We certainly think of the most influential component as a hormonal component, but we know there are a lot of neurotransmitters that are involved there as well. And so that's sort of the normal teaching, right? That's why I want you to talk about that. We do see this libido seems to decrease as women age, but is it multifactorial? And we're all just throwing it in that hormonal bucket and blaming it on just a lack of hormones of menopause. So what are your thoughts on that?
Desire is an amazing topic. It is not easy. It's not simple. It's different for everybody, and we got to start with the basics. So if you break down two different types of desire, we've got responsive and we've got spontaneous. Spontaneous is your new relationship energy. You are it's like your brain is on crack. It doesn't care about work. It doesn't care about food. It doesn't care about anything else. You got this new person in your life that is hot and heavy. That is spontaneous desire. That goes away. The brain normalizes. The brain adapts. It gets used to stuff. That new relationship desire goes away around 12 months. So in our society, we have put on a hierarchy that monogamous relationships, long-term monogamous relationships, are something that we participate in. That's fascinating. But we can't say, I'm in this 10-year relationship, I wish I had spontaneous desire. It's not how brains work, right? So it's really understanding the brain. And also, that's what we're sold. That's what Hollywood is. That's what music is. It's really telling us that spontaneous desire is the default. One might argue it might be the male default. Testosterone's of 800 will do that to people. But it's really not everybody's lived experience. And it's quite normal to have responsive desire. What responsive desire is I'm busy, I'm at work, I'm thinking about other things, I'm not thinking about sex. But when I'm put in a sexual context, my partner and I are starting to get together, I'm starting to think about it, we're starting to feel it, now I want sex, I'm happy having it, it's a great time. So when a woman comes in and she says, I have low desire, I always say, why is that a problem, right? And the question is, do you like sex? If she doesn't like sex, she doesn't have the orgasms. She's doing it for somebody else. She's doing it to keep somebody else happy, whatever it might be. You can't desire that. You do not have a low desire problem. You have a sex is an awesome problem. My analogy is I love Haagen-Dazs mint chip ice cream. I will eat it. I have spontaneous desire for Haagen-Dazs mint chip ice cream. You give me melted ice cream, I don't want it. So that is if the sex isn't good, of course you're not going to desire it. That's dopamine. You have to have something worth desiring in order to create the desire. And then as far as the responsive desire, if you love having sex and it's great and you always forget how good it is, it's just lovely, you just get busy, that's not a problem either. Prioritize sex. Again, we don't get taught scheduling sex. I don't spontaneously want to work out, but I'm a very fit person because I love it when I do it and I want it in my life. I don't have spontaneous desire for working out. Same with vegetables. So it's if you think about sex as a just not unique thing, it's just another thing in our life of if you want to prioritize it, prioritize it. An amazing sex life doesn't help in ourselves.
You're making me laugh.
Good.
Sex, lima beans.
Exactly.
She brings vegetables into the conversation.
It's normalizing an otherwise awkward conversation, right? That's what you have to do for patients. Otherwise, they can't listen if you can't make them laugh. And you can't normalize it yeah, I want to exercise, but unless I prioritize it, it's not going to happen. But I love it when I do it. I love it in my life. There's an amazing book called Magnificent Sex by Peggy Kleinplatz, and she looked at all these people. She basically said, who's having amazing sex, right? These people raised their hand. She researched them. Not one of them said they had an amazing sex life because of spontaneous desire. That is not an ingredient in a wonderful sex life. It's prioritizing, it's communicating, all of the good things that creates for an excellent sex life. So that's why desire is so fun and interesting, because nobody knows anything about it. They all think that it should be like Hollywood, Tom Cruise and Cameron Diaz or whatever. That's not how it is. And you can have an amazing sex life without having spontaneous desire. When you get into perimenopause and hormones that you asked about, that was the myth. That's why I got into hormones, because people are like, yeah, but you know what happens to sex after menopause? And I'm like, what's the data show? So I did the same thing that I did for female sexual health. I'm like, let's go look at the menopause data and sex lives. The 2 top reasons that women stop having sex after menopause: number 1, availability of partner. Number 2, vasomotor symptoms of menopause: hot flashes, night sweats, poor sleep, worse mood. Well, I can't help you with the first problem, but now I can help you with the second one, right? You get a woman feeling better, her desire can naturally come back up.
So when we think about the vasomotor symptoms of menopause, we think about replacing the estrogen. Of course, if they have a uterus, a progesterone too, for safety issues, but also progesterone can be helpful for insomnia issues and other kinds of things. But let's just get into the big taboo, capital T, testosterone. It's not really a taboo, not in my world, but in many people's worlds it still is. And they're very leery about dabbling in the testosterone pool. Tell us a little bit more about the importance of testosterone, or how it's used, if it is used in women, what your experience has been with it.
We're at the tip of the iceberg on this. This is going to start getting big, I think. And you got to step back. Did you learn in medical school that women had more testosterone in their bodies than estrogen?
No.
I did not. I learned that about 3 years ago. The reason he doesn't even look that way in the labs, because they're measured, and like one's picograms per milliliter and one's deciliter per blah, blah, blah. So that you actually have to do the conversion. So I did the conversion on my labs. And unless you're pregnant, because that's a pretty high estrogen level, at all times, you have more testosterone in your body than estrogen. Women did. If you Google testosterone, it says the male hormone on Google. Like, we have a branding problem with this hormone. We gendered hormones, and it's hurting us. It's going to continue to hurt us. Also, men have estrogen, and they have problems when their estrogen goes down. Fascinating article on blocking men's estrogen and seeing what happens. So we all have these hormones, just in variable amounts. Women have more testosterone than estrogen, just on average about 10% the amount of testosterone that a man's body has. So that's where you have to start, because if I come hot and heavy in being like, oh my God, you should give women testosterone, it sounds insane unless you back up and understand the physiology of bodies. So we say ovaries make estrogen. That's what we learned. Ovaries make androgens, which get converted to estrogens. You cannot have an estrogen molecule without it passing through one of 2 androgens in our bodies. That also helps us understand why testosterone is important, right? So testosterone will go a little slower down after menopause, but there is a role for testosterone in perimenopause as well. I've treated a lot of women who are not quite done with their periods with testosterone. The acceptable, air quotes, acceptable reason to give a postmenopausal woman testosterone is low desire. That's a whole bunch of bias. Why is the only reason for a woman to have testosterone to make her want to sleep with somebody? Like, once you sit and meditate on that, it is insanity, right? Like, that's a nice perk, but is that the only legitimate reason? Same thing I do with sex, same thing I do with menopause, same thing I'm doing with testosterone. Deep dive into the literature. We've been giving women testosterone since the 1940s. This stuff has been around for a very long time. We've given it to try to treat breast cancer with it. We've got data that say it decreases your risk of breast cancer. We've given it to women post-breast cancer. We've got tons of testosterone data, yet here we are in a country that does not have an FDA-approved testosterone product because of the FDA saying we need years more of safety data compared to a man's testosterone product to prove safety. We have gender bias in what it takes to get a product approved. So we're pushed into using an off-label product. We can use a man's testosterone gel, dose it appropriately for women, or we have to do compounded, or we have to do pellets. People would argue pellets are super therapeutic, so you're going to get a lot more side effects. Some people get benefits. Some people do very well at those higher testosterones, but you're seeing a lot more side effects than if you could appropriately dose a testosterone product with something that was FDA approved.
So, there was such a hype. Using testosterone for female sexual dysfunction was the term FSD. It's the end of the 90s, early 2000s. I was around then in urology, and people were either jumping on the bandwagon, seeing what was happening with this or not. And we really thought it was going to be something. I know I dabbled in that area, giving women Testim, right? A little, because there wasn't, to your point, there wasn't anything that was marketed for women. And so we used it off label. And it really fell by the wayside, unfortunately, I think. And they were scared to use it. I think it's because the FDA didn't back it. What kind of work do you think we need to do, really, to get the FDA to listen to the importance of these hormones so that we can get a commercially available product for women?
Yeah. Yeah, I think going back to the 90s, I think the testosterone falling off happened for two reasons. Number one, I think we underdosed testosterone, right? A lot of studies that tried to get through the FDA, it showed great safety, but not great efficacy. And I would argue that we weren't dosing high enough to see efficacy. And then the other thing is we can't take this big umbrella of sexual dysfunction, throw testosterone at it, and expect testosterone to fix all of it, right? Like, testosterone only helps sexual dysfunction when it's a low testosterone issue. So again, it will not fix your relationship. It will not make you want him more. It will not make you resent him less. So like you take sexual dysfunction and you're like, testosterone doesn't always work. And it's like, yeah, obviously, right? Like until you understand the complexities of sexual dysfunction. Same with men. You give men with low erections and low testosterone, you give them testosterone, their erections don't always get better, right? So I always like to say, like, women are not overly complicated. We just don't understand this enough. What we need, yeah, it's a fascinating topic because testosterone is a hormone, naturally occurring. You can't patent it. You can patent the way it's delivered, but you can't patent it. What does that mean? That means it's going to require about $1 billion for a pharmaceutical industry to go through the necessary safety studies that the FDA is requiring, again, above and beyond what they've required for a male product. Who's going to pay $1 billion for more years of safety study for basically something that's already generic, just to get it dosed appropriately? So, I mean, I'm stuck in a bind, right? Because I'm like, I want more women to have access. I want doctors to feel comfortable that they don't have to be like, take this gel and dose it at 1/10 the dose, which is like super teeny, right? But if you're just going to put it in a pink box and jack up the price to $400 to pay for your $1 billion study, have we actually helped anybody? And what are we going to need to do to get insurance companies to approve that product? Now, one country in the world has a dosed appropriately testosterone product. That's Australia. That company is coming to they're currently doing studies in the UK. And I have heard they're coming to I got to get them on my podcast, but I have heard they're coming to do studies in America next. So it's coming. But again, for the reasons I said, I'm not sure it's going to be available to everybody. Pink boxes are expensive.
Yeah, I know.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Overjinsky.
Show notes and social media by Jody Lenora.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.